Hi everyone. I wanted to do another sort of string of videos, another sort of selection of videos about different types of health problems, particularly musculoskeletal problems that people typically have, and to try to give some understanding of what's happening behind all those issues. The first one I'm going to talk about is sciatica. A lot of people have sciatica, which is like a pain down the back of the leg, and the first thing to talk about what's happening behind that is that we actually break sciatica down into two different things. Now, sciatica was always thought of as being a pinching of the nerve, the sciatic nerve that goes down the back of your, through the back of your hip and down the back of your leg. So one thought is that there's a pinching of that nerve, but then we can also have symptoms down the back of the leg, which are not because of pinching of the nerve, and that we call a sciatic distribution of pain. So in other words, you have pain where the sciatic nerve goes, but it's not because of pinching in the nerve. So why is this important? It's really important because most of what I see in my practice, and it might just be my practice, most of what I'm seeing is a sciatic distribution of pain rather than sciatica. So one of the ways we can differentiate this, actually there's several, I'm not going to go into the whole gamut of it, but one of the things is that if you have a pressure on the nerve, you're going to create some long-term changes in the function of that nerve. So even if you did have a pressure on a nerve and then you were to take that pressure away from the nerve, you would not necessarily see a total return of function, because what's happened is when you put the pressure on the nerve, you're damaging the nerve, and that damaged nerve isn't going to function appropriately. So if you were to take the pressure off, you'll still see that you do not have function. So one of the ways that you can, easiest ways to figure it out is to try to treat someone in some way and see if you regain function. So this is what I typically see in treating sciatica. So again, I'll just refer to it as a sciatic distribution of pain because that's primarily what we're going to be talking about, is that someone has pain going down the back of their leg. Now there's a whole sort of presentation that very often goes with this, and I'm going to work through some of the components of that. The first primary component is that there's an imbalance of muscles on the back of your hip and back of your thigh versus muscles on the front of your hip and your thigh. So we can break muscle groups down into flexor groups and extensor groups, and what we'll find is that in a sciatic distribution of pain there'll be more tension of the flexor groups. Now it gets a little bit confusing because you think of your glutes as being extensors, but basically think about your muscles that are bringing your leg towards fetal position as being flexors, and muscles that are bringing you away from fetal position as being like the extensors. It's not entirely accurate as well because we have to include the deep gluteal muscles in those flexors. So if we have the deep gluteal muscles and we have muscles on the outside of the hip, like tensor fasciae latae on the outside of the hip, that's an extensor. So what you usually see is that the deep gluteal muscles will be tight and the extensor muscles like tensor fasciae latae will be weak. So we see, if we test the muscle, we'll very often find that people with sciatica will have a weak tensor fasciae latae. Okay? So tensor fasciae latae, what it does is it, when you take a step, what's going to happen is that your body is taking a step from one leg to the other leg. So you're moving, say, from your left foot to your right foot. What that tensor fasciae latae does is brings your leg out to the side, out and forward. But effectively, when you step on that leg, what's happening is because your body is going from left to right, the tensor fasciae latae is going to act as a brake to keep you from further going in that direction. So the tensor fasciae latae is going to stabilize the hip and break that motion so that you don't shift too far that way. When someone has a weakness of tensor fasciae latae, oftentimes we'll see that the hip will drop, so we can see that there's a hip instability when we're watching the person walk. But at the same time, these people that say, oh, my legs feel heavy when I'm going up the stairs, because you do use it a bit to lift your legs, and particularly when you're going downstairs as well, you're stepping onto that leg and you're hoping that that muscle is going to contract to stabilize your hip, but when it doesn't, you feel like your leg is giving way. So sometimes people will be standing there and they feel like their leg gives way. is very often a weakness of tensor fasciae latae. So one of the ways that our body compensates around this is that your body will try to contract another muscle to take the place of tensor fasciae latae. And tensor fasciae latae attaches into the iliotibial band, which goes down the side of the thigh and attaches below the knee. So it also acts as a brake of leg. So basically we have our thigh and our leg. The lower part of your lower extremity is your leg. So if you have your knee, the iliotibial band and the tensor fasciae latae that's attached to it can actually limit that forward translation of your knee. So if you have a weakness of tensor fasciae latae, you might have what we call an anterior draw sign or positive anterior draw sign, because as I pull your leg forward, if there's not sufficient resistance in tensor fasciae latae, we're going to see that leg will come too far forward. It might also rotate more to the inside, so it will internally rotate more. In other words, there's less resistance to stabilize that joint in external rotation. So that internal rotation would be too easy, and forward translation at the knee will become too easy. If the tensor fasciae latae is weak, does it have an effect on the knee? Yes, it does. Because if you don't have that stability, that ability to limit that forward translation of the knee, if you have that anterior draw sign, the thing that's going to resist that is your anterior cruciate. So if people don't have that stability, then if they put themselves in a position or a motion or some sort of situation where they need to have that stability, say where they're skiing or they're doing some stop and go type of sports activities, their body can't stabilize and resist that motion, so the joint will move to its end range and then damage the anterior cruciate. So it's very often that someone has an anterior cruciate issue and they have a tensor fasciae latae. How I see this in practice is I see it without anterior cruciates, but very often people will come in and they say, oh, I had an anterior cruciate tear, and I see that they have a positive anterior draw sign, and also they'll have a weak tensor fasciae latae. So if we can strengthen the tensor fasciae latae, then we immediately see that there's less motion in the anterior draw. So this is very, very important. So it's really interesting that a muscle that's stabilizing the hip can also stabilize the knee as well. Now, this introduces a whole cascade of other compensations. So if your tensor fasciae latae and iliotibial band aren't capable, and you also see a lot of tension in the iliotibial band as well, if the iliotibial band isn't, and the tensor fasciae latae particularly aren't able to stabilize that, what's going to happen is your body's going to compensate by contracting rectus femoris, which is one of your quadricep muscles. It crosses the hip joint for one, but also crosses the knee joint. Just like tensor fasciae latae, it crosses the hip and it crosses the knee, but it has a different action. It's meant to flex the hip, and it's also meant to extend the knee. So it doesn't have exactly the same action, but what it's trying to do is trying to resist that anterior translation of the leg. But it's not perfect, because it's an extrinsic muscle, and it'll be contracting all the time. What you'll end up with is that muscle contracting, it's connecting into your patella, your kneecap, and when it's contracting all the time, it's going to put a load on the front of the knee. So what you'll find is that people have sort of pain underneath the knee or some wear and tear where the kneecap is rubbing over the rest of the femur. And in those situations, you palpate the rectus femoris, you'll find that there's tension there as well. Another thing, again going back to that forward translation, we say that it's limiting that internal rotation. So if it doesn't limit it, very often what will happen is popliteus on the back of the knee will be tight as well. So if a popliteus is tight, that's going to create more of a rotation, because the popliteus is meant to unlock the knee joint. So if it's tight, it's constantly going to be unlocked, but it also rotates as well because of its orientation. It's going to rotate the knee. So that constant rotation, every time you're flexing and extending, is going to put a stress on your knee. And very often, what I'm seeing is a stress on the not only on the cruciates, but also on the meniscus, particularly the medial meniscus. So a lot of people come in with sciatica, or they come in with legs that are giving way, or they come in with an anterior cruciate problem, or they come in with a meniscus problem, and very often it's the same thing. So we have this imbalance of the muscles. The tensor fasciae latae that's stabilizing the hip, and the deep gluteal muscles, which are very, very tight. So again, I said at the beginning that those are flexors and extensors, but if we have tension of the deep gluteal muscles, we'll also have tension of the hamstrings, we'll have tension of popliteus, which again is a flexor, and some of the muscles in the leg and in the foot even as well. So we have a whole sort of series of flexor tensions and extensor weakness. So in order to really look at that, I think a lot of people in the neurological community know how you could have an extensor weakness. We have pyramidal paresis. That's one of the mechanisms. It could be because of pyramidal paresis. I think it could also be because of an instability in the lumbar spine. So very often I'll do something to try to stabilize the lumbar spine. I'm not thinking about suprasegmental pathways. In other words, I'm not trying to stimulate the cortex to try to activate those prefrontal descending pathways to inhibit flexor tension and allow for greater activation of extensor tone. I might just be treating something locally at the lumbar joints and try to create some stability there. And very often I'll see that we get a strong tensor fasciae latae that can maintain. So I think that there is a suprasegmental component, most definitely, and when there is, I treat that. But at the same time, I think we have to look at lumbar stability, because I think that's one of the key components as well. So I hope you guys find that interesting. I'd love to hear your comments about this, and look forward to hearing more from everyone. And I'll talk more about other types of issues as well. So I hope that's useful for you. Thanks for watching.